My name is Fei Wang. I'm an adult hematologist specializing in thrombosis at the Ottawa Hospital and the University of Ottawa. I have the distinct pleasure to have this roundtable discussion today with Dr. Cecilia Bahit.
Hi, it's a pleasure to be here. My name is Cecilia Bahit. I'm a clinical cardiologist based in Argentina.
Thank you, Dr. Pahit. So today our round table discussion will focus on really discussing the anticoagulant use for the cardiology patient population and also discussing factor 11 inhibitor. So based on what we know from congenital factor 11 deficiency patients, factor 11 seems to have a more important role for thrombosis than for hemostasis, which might be an ideal target for anticoagulation. So factor 11 and 11A inhibitors are therefore developed and actively investigated in many phase 2 and 3 studies as novel anticoagulant options in the recent years. There are many types of factor 11A inhibitors working through different mechanisms, including antisense oligonucleotide and small molecule inhibitors or monoclonal antibodies to reduce the levels of factor 11 and 11A. So we'll be discussing some unmet needs in the current anticoagulant field, and also discussing what factor 11, 11A can bring. So first, to start with Dr. Bahit, what do you think the unmet needs of cardiology patients in regards to anticoagulation therapy and the limitations for the current available anticoagulation trials?
Well, this is a great question, and I think that a couple of years ago we thought that we found, the solution for or the best treatment as oral anticoagulants with direct oral anticoagulants. However, we realized that there were some unmet needs that I can explain in a little more detail. We know that in prior trials, pivotal trials, direct oral anticoagulation, there were patients who were at high risk of bleeding who were not included in those trials, such as patients with prior bleeding events or renal insufficiency, some cancer patients, and even, elderly patients. There are other group of patients that were not, assessed, and that were patients who have some type of cardiovascular device. So I think that these are the areas where, the DOAC studies fell short. And I think that's exactly where there are the unmet needs. In particular, in cardiology, there are two big, sets of clinical scenarios. One would be the post-acute coronary syndrome period when we see a lot of recurrence of event that despite current therapies, we continue to see patients who present with acute MI or other events. And in patients with atrial fibrillation, we know that we don't have a response for those patients who have a high risk of bleeding or renal insufficiency or those who were considered suitable for oral anticoagulation.
Yeah, that's great. Yeah, I would say that from a hematology standpoint, and we also see a lot of patients who either have atrial fibrillation, or obviously we see a lot of VTE patient also face the same limitations that especially for renal insufficiency patients and in patients with high risk of bleeding, and we've seen a lot of providers have been quite hesitant of giving anticoagulant, and that actually in and of itself could also lead to complications for patient developing blood clot and in stroke, and then you end up having to deal with the complications. So yeah. So how do you think that factor 11, 11A inhibitors will address this unmet needs to change the therapeutic landscape?
So as you mentioned before, the unique characteristic of factor 11 inhibitors is the way they block the coagulation cascade. In a way, they prevent the bad clot from forming, but these inhibitors do not affect, the normal or the good clot, as I like to call it. So it's in a way they uncouple, hemostasis and thrombosis, and in this way there's a better safety profile expected with hopefully a great effect on clinical events. And that's how we all see these agents as potential and promising targets. If I may explain a little more, for example, in the setting of post-acute myocardial infarction, we know that thrombin is elevated when a patient presents with an acute myocardial infarction, and in those patients in whom there's persistent thrombin, formation or generation, those are the ones who have higher risk for recurrent events. different strategies trying to target that have been tested, with rivaroxaban and with Rapaxor. However, they showed benefit on clinical events but increased risk of bleeding. And I think, particularly, the beauty of factor 11 inhibition in this setting is that potentially they will be able to provide, this balance that is so needed, to prevent cardiovascular event, but also not to cause excess bleeding.
Yeah, definitely. And I think there's are some kind of phase two or maybe even phase three studies ongoing right now. Would you mind to kind of give us a kind of brief overview about what's going on right now and what's in the future that you can see?
So there was a phase 2 trial called Pacific MI using asundexian, which was a small molecule factor enabling inhibitor that showed no increase in bleeding versus placebo with a dose-dependent, inhibition of factor 11. And in phase 3, that program decided not to move forward, and there's one only ongoing trial, which is called the Brexia ACS, that is looking at milvexian, which is another factor 11 inhibitor, a small molecule versus placebo in this setting.
So, Dr. Becky, how do you think hematologists and oncologists can better collaborate with one another for these cardiology patients?
I think that we've been able to collaborate with hematologists, over the last decades. Sometime before, when we only had vitamin K antagonists, we cardiologists would send the patient to the hematologist to be anticoagulated. But since the introduction of direct oral anticoagulants, since that time, we've been able to prescribe, the anticoagulants and the hematologists too. We've been able to partner in the care of the patient. And I work in a place where we have a multidisciplinary team. And even though I might prescribe, the direct oral anticoagulation in a patient who has atrial fibrillation, the patient is seen by the hematologist, and if he or she finds out that the patient is having, I don't know, some cardiovascular symptoms, I would be calling, or the other way around. If there's an issue with, I don't know, with bleeding, or we work together as a team trying to provide what the patient needs. So I think that I foresee an even better partnership between cardiologists and hematologists.
I could not agree more. And I think one of the unique kind of situation for the cardiology patients, also the concurrent use of antiplatelet agent that's quite commonly used currently as standard of care post MI or for other things. So a lot of times when we, for other reason need to start anticoagulation, we kind of also will reach out to our cardiology colleagues to see that, say, if we can de-escalate the antiplatelet or do we need to, or those kind of things. So I think those are certainly are important collaboration and hopefully to continue to do so to help these patients.
And I think this is key. Each patient is an individual who had a different history, and we need to sit down and discuss, the particulars of that, whether there's a need to continue, antiplatelet therapy, as you were mentioned, because we know that the more we add to that, the higher the risk of bleeding. So discussions, are very almost daily. We have daily discussions with hematologists for certain patients, and we do have a day in the week where we exchange, notes on patients and make decisions.
Okay, great. So finally, if you wouldn't mind, maybe we'll go summarize. What do you think the future holds for these patients for ND therapies?
I think factor 11 inhibitors will provide uh, the the answer to this relevant question that have not been answered by direct oral anticoagulants. Of course, we have to wait phase 3 trials to have the proof of concept, and of course, to show the evidence that they are safe, but also they are effective. And I think that the future is promising, and we will be able to hopefully to provide care for these patients who haven't had an answer for their issues. Let's say patients with high risk of bleeding or renal insufficiency in this area.
Great. Thank you so much, Dr. Bahit. I think this round up our roundtable discussion. I hope this is useful and helpful for our audience. Thank you.